Good afternoon, and welcome to our final event in our Telescope, the New AIDS Epidemic series. It is the first Telescope event under our new rebranded events department, Politico Live. So I'm very happy to have you joining me here today online. I am Sarah Wheaton. I'm the Chief Policy Correspondent for Politico here from Brussels. And we're meeting virtually today at a time where we have the 40th birthday, essentially, of the HIV virus. It's the 40th birthday of the epidemic, and we are still trying to find it. We have a new updated strategy for ending the epidemic by 2030, and we'll be talking about that in more detail today. But first, I want to give you a chance to ask some questions over Slido. You know, at Politico Live, we always like to have our events be interactive. So go to Slido and use the hashtag Politico Telescope AIDS. You can go to Slido on your computer or phone. And we already have a poll up. It's a word cloud poll, as you can see, and the question is, what is going to be the biggest challenge in the fight against HIV until 2030? So there are already some things in here, but this is totally whatever you want to say. So if you see it being more of a science challenge, let us know. If there's a particular country that you think is causing the biggest holdup, can put this here. We also have some kind of thematic responses from people already. Also, we encourage you to tweet, and if you use the hashtag Politico Telescope AIDS, then we'll catch it and put it up on the screen that's behind me here. So with that, I'd like to introduce Neil Mulcock, the Vice President for International Government Affairs and Policy with Gilead.
Good afternoon. Just checking that you can hear me.
We can. Thank you.
Great. Thank you, Sarah. So on behalf of Gilead, I'm delighted to welcome you all to the closing event of the Politico Telescope series, which we're very pleased to support. Over the past year, the importance of the COVID pandemic has made everyone acutely aware of the value of science and the importance of robust public health policies and healthcare systems to tackle infectious diseases. The speed at which solutions were able to be found to treat and vaccinate against COVID-19 is a testament to the dedication of scientists, both in academia and in industry, and the public institutions and agencies that we all worked with. The fact that we were able to take compounds from the lab to the patient in little under a year is remarkable, and is a testament to all those that are involved. And what this health crisis has shown us is that when there's a political will, our healthcare systems and governments are able to work together quickly and effectively. And we need to continue with this level of cooperation post-crisis. Today, as Sarah mentioned, we officially reached the end of the Politico's Telescope investigation of HIV. And at Gilead, we've been pleased to support the series. We've moved from a general investigation of the challenges presented by HIV and the progress made in Europe in addressing those challenges to identifying best practices and actionable solutions that the EU and its member states should consider when working towards ending the HIV epidemic. Before we continue, though, and as we mark the 40th anniversary since AIDS was first identified, it is important to remind ourselves that over 75 million lives have been infected with HIV, and 32 million have died from AIDS-related illnesses. 32 million lives lost to HIV, or over 800,000 people a year since HIV was first identified. But the scientific effort and clinical progress made in tackling HIV has also been remarkable. Years of advocacy, scientific discovery, and political will has turned HIV/AIDS into a manageable yet lifelong condition. And additionally, we have the knowledge today and the tools to prevent new HIV infections. Gilead is proud to have been at the forefront of these scientific efforts to defeat HIV for over 30 years. Working in partnership with people living with HIV, the scientific community, policymakers, and governments. And today, as a result of that partnership, people can live and grow old with HIV. When on antiretroviral treatment, a person living with HIV can reach viral load suppression with effectively no risk of transmitting HIV. But unfortunately, this is not a reality for everyone living with HIV. Persistent inequalities make living and growing old with HIV harder to achieve, and issues such as lack of access to effective treatment, stigma, discrimination, and social injustices remain. Despite the tremendous progress achieved so far, 690,000 people died of HIV in 2019. And if we look across the European region, estimates from the ECDC and WHO report that approximately 25,000 people were diagnosed with HIV in 2019. And it is estimated that a further 120,000 are living in the region with HIV and not aware of their status. This means that about 1 in 7 of those living with HIV are still not aware of their status. So clearly, we are far from the end of the HIV epidemic, and the clock is ticking towards the 2030 deadline set by the UN Sustainable Development Goal 3, namely to end the epidemic of AIDS. There's still much work to be done to meet that goal. Continuous innovation in treatments and public policy is needed to address inequalities and to combat HIV-related stigma and discrimination. At Gilead, we know that ending the HIV epidemic must be done in partnership. And some of our collaborations addressing HIV have been highlighted in our contributions to the Telescope series. Among them, our ongoing support of the Fast Track City initiative. In France, since 2018, Gilead has supported the implementation of local programs on awareness, prevention, screening, and linkage to care as rapid initiation of HIV treatment. Another example is Radian, a partnership launched by Gilead and the Elton John AIDS Foundation in 2019 to support local initiatives in Eastern Europe and Central Asia with a view to improve and strengthen access to HIV prevention, testing and care, and also to reduce HIV-related stigma. The new UN AIDS Global AIDS Strategy, published only a few months ago, has raised the bar by moving from the 1990 targets to 1995. This is a stretch goal for many governments because as of 2019, only 4 European countries have met the previous UN AIDS targets. So how can we be more ambitious and ensure that countries in Europe move faster to reaching HIV elimination by 2030? We suggest 3 objectives. First, tackle social injustices and inequalities. UNAIDS stated this very clearly in its new strategy. If we're to end HIV once and for all, it is critical to address the outstanding barriers to reach this goal. Second, prioritise a patient-centred care. Health Commissioner Kyriakides stated in a speech in the last World AIDS Day event organised by the HIV Outcomes Initiative that we need to, quote, start treating the person and not the disease. I echo those words. It is time to move beyond viral suppression when tackling HIV. As a member of the HIV Outcomes Initiative, we strongly advocate for the adoption of policy measures that can ensure well-being and health-related quality of life for all those living with HIV. And finally, we need to foster access to biomedical advances in preventing and treating HIV. The COVID pandemic has shown how innovation can be a key driver in tackling epidemics. This, of course, includes HIV. If we're able to stop HIV by 2030, political support and funding from all EU member states must be of the utmost importance. To achieve these 3 goals, we need the EU and member states' effort to renew their efforts against HIV. We need national action plans across Europe that define clear and achievable objectives to meet those targets set by UNAIDS. And from now on, I'd like to step back and leave the floor to the distinguished panel of experts to present today from the various organisations and countries. And I'm very much looking forward to having an interesting discussion and debate on how we can move faster towards ending the epidemic in Europe. Thank you.
Thank you so much, Neil. And indeed, let's move on to the panel. You did a great job, Neil, of really setting the stage for this discussion. And as we said, as the name of this event signals, we've moved from the 90-90-90 goals for 2020 to the 95-95-95 goals for 2025. And Vinay Saldana, as the special advisor to the executive director of UNAIDS, you've basically been in charge of, pushing this strategy across the finish line, helping put it together. But, going from 90-90-90 to 95-95-95, just moving the goalpost bit seems pretty straightforward. Is that all there is to it in this new strategy?
Thanks, Sarah, and thanks for inviting UNAIDS to participate in today's really important political live discussion. I was only one of a big team, not only at the UNAIDS Secretariat, but we are quite a little unique in the UN system in that we're a joint program. So we actually have 11 co-sponsors, including WHO, UNDP, UNICEF. I won't go through the whole list, but we work together as kind of the UN's voice and joint program on AIDS in all countries, and at the global and even at the regional level. And so while with the support of member states, the goalpost was moved quite deliberately from 90-90-90 at the end of 2020 to 95-95-95 by the end of 2025. But the change is actually more important than just the numerical change in the targets. For the first time, you've got both a global AIDS strategy and a UN General Assembly political declaration that specifies that the 95 targets need to be reached in every subpopulation. And so what does that mean in practice?
And Vinay, I realize we should be saying, I don't mean to interrupt you, but we should be, for those of us who are not immersed in this world, 95, 95, 95, what are those each touching?
Sorry, thanks, Sarah. Important nuance. So the so-called HIV cascade is the new targets, the 95 targets, are based on the aim of ensuring that 95% of people who are living with HIV know their status. 95% of people who know their HIV positive status are on life-saving antiretroviral treatment. And 95% of those on treatment reach what are called undetectable viral loads, which essentially means that the person's taking their treatment properly, the virus is completely under control, undetectable in a viral load test, and that means that the person has no risk of progression from HIV to AIDS, as well as no risk of onward HIV transmission or sexual transmission of HIV to an HIV negative partner. And so the 90-90-90 targets weren't reached by the end of 2020. And despite that, the world has raised the bar again and said, okay, because we've done a lot of modeling. It's not only because it's a nice catchphrase, 95-95-95, that actually doesn't fit into a soundbite so well, but we've done a lot of modeling to show that if the world doesn't reach 95-95-95 by the end of 2025, we're actually not going to end AIDS by 2030, because the last mile is always the hardest mile, and we're actually not even on track to reach the 95s right now. But getting back to what I was saying earlier, this also requires that a country or a city even can't do well only on reaching the 95s at the aggregate general population. It actually has to reach the 95s in every subpopulation. So amongst women, amongst migrants, amongst youth, amongst children, amongst newborns, amongst sex workers, amongst men who have sex with men, which actually requires that countries and partners develop population size estimates to actually know, okay, well, how many sex workers do we have in our country? Right? How many estimated gay men and men who have sex with men do we have in our city? And then calculate the progress annually against the cascade amongst all the different subpopulations. So there's a lot of work to do, including in Europe, because quite honestly, from the data that we get at UNAIDS, many countries actually either don't create estimates or population size estimates, or don't track these cascades across all the different subpopulations. So it is an ambitious ask or task to reach these new targets, but this is what it means about getting serious about ending AIDS, getting very granular and being ambitious, not only to reach the goals at an abstract national level, but within every community and every population that is affected by HIV.
Thanks, Vinay. And Manuel Pizarro, you're now a member of the European Parliament representing Portugal, but you used to be Portugal's Secretary of State for Health, and you're a medical doctor as well. So you have great visibility into all of these different levels. What should be happening? Let's start at the European level to move towards these targets.
Well, thank you, Sarah, and let me thank you for the invitation for this important meeting in the Political Live. I must be clear, we need, of course, we need a lot of innovation, we need scientific investigation, we need medical and other health professionals, but I must be clear, to tackle HIV infection now is mainly a political issue. With the knowledge that we have now, we are able to find a solution to that disease and to eradicate the disease in 2030 if we get all the political measures that we need to do that. And I think that to achieve those goals, we must turn the disease visible, because there still be a lot of stigma and a lot of discrimination about this disease. As you all know, now the two main risk behaviors for the disease are sexual behavior and use of drugs by endogenous drug users. So these are those kinds of behaviors that we don't want to speak loudly and speak frankly. And I think that we must overcome this issue. We must speak about things. If we want to catch people, to diagnose people that live with HIV and doesn't know that they live with HIV, we must do something different. If we do business as usual, as it's in the title of this program, we will not catch them. In Portugal, I think that we have much success in two areas. First of all, we managed to deal with the issue of people who use drugs. It was a very difficult issue in our country, and we are the first country in the world in 2001 that decriminalization of the use of drugs and the possession of drugs for own use, and this was a very huge change, because we managed to approach people of the health system and put them out of the justice system and bringing them where we want them in the health system, and we have a great success on that. Now it's not important in our country, the transmission amongst the drug users. But we have another problem. People who live with sex workers and people who use the services of sex workers. This is a very difficult cultural background in our country, and it was very difficult to address this issue. How do we manage that? We convinced the medical practitioners, mainly the family doctors, to transform the demand of the HIV status of the people as a routine analysis. Of course, we must ask people if they agree, but with that strategy, we discover a lot of people who was completely unaware of the possibility that they get HIV infection, and they were diagnosed. And this was a very important first step to arrive to the other steps, because as Dr. Saldanha very well explained, the first step is to make the diagnosis. If we don't get diagnosed, it's not possible to treat, and it's not possible to suppress the HIV. And I think this is a question. I must insist on that. This is a political question, because we must have resources to do all the massive public campaign to put people aware of the risks. But we also must have a political clear speech against stigma, against discrimination. This is a viral infection. We must not be guilty of getting a viral infection. We must be, of course, aware of the risk behaviors, but we must address that as a disease that is possible to manage and should be managed. And if we manage the disease in ourselves, we will live happier, with more quality of life, more years, and mainly we will not put others at risk of contracting the disease. And I think that we should insist and insist and insist, because there is one risk, and I will end up with that, is the risk that if we have a great success in discovering effective treatments, they can suppress the disease, and the quality of life, and mainly the duration of life of people with HIV is almost equal to the other people. But there is a risk to not give value to the infection. The infection is a serious health problem. People must take medicines for all the life. There are, however, some side effects of the medications. Quality of life is not exactly the same of other people. And when people get elderly, some consequences of infection of the treatments came over and disturbed the quality of life. So we must give importance to the disease, to tackle the disease. Thank you very much.
Thank you so much, Manuel. That's an incredible overview. And let me quickly, before I go to our other panelists, let's take a quick look at the word cloud to see what people say. It's actually been kind of shifting around a bit as people have been listening to some of the speakers. But we can see stigma and political will really standing out. Funding was big in the word cloud a little bit earlier in the discussion, but is kind of shrinking a bit. But of course, those things are all interrelated. Andrew Ullman, you are an MP in the German Bundestag and a member of the health committee there, the subcommittee on global health. And if I'm not mistaken, you're also a medical doctor. And Germany has, as Manuel mentioned, we have effective treatment for HIV. It now is something where if you're on treatment, you can basically have a normal lifespan. Germany has a well-funded science-based health system. What are the big gaps to finally ending this in your country?
Well, maybe before I start, first of all, thank you very much, Sarah, and thank you very much for inviting me here to your session. But maybe we have to have a brief look at the numbers in Germany that we're facing, how many people are affected by HIV. And in Germany, we had in the year 2019, these are basically the latest numbers, around 91,000 people were living with HIV. And every year, about 2,000 to 2,500 people are newly diagnosed with HIV. And half of them get this diagnosis once they are ill, so rather late. And if we were looking at, I would like to call them the triple 90 numbers. Those people in Germany diagnosed with AIDS, 88%. So we're below the 80 threshold, but the other numbers look a lot better. 96% of the diagnosed people with HIV receive medication. And in 96% of the HIV population, HIV is by PCR testing not detectable. So this is a good setting, but we see the weakness in our country, and the gap that we're facing is prevention. As my colleague Pizarro just said, that prior to the treatment, you need to have the diagnosis. I would even go a step back. You don't have to be a diagnosed if you can prevent the disease or the infection right from the front. And this is why Germany is focusing on the strategy on prevention. This includes engagement and empowerment for those groups that are of the higher risk. The risk factors were just mentioned here. And also a comprehensive prevention services, meaning access to sexual or reproductive health tools, early testing, so we need a low threshold on testing possibilities, and of course, rapid access to treatment and financial support. It is very much obvious that we need this kind of partnership very much. But the increase of number of infections shows that these efforts are still necessary to improve our situation, our country, even though we are have reached already the 95, the last two numbers, so we still have to get to the first to get this better. But what we see here as well, besides these easy numbers to look at, we have to see that quality of life is very important. And in a study, which is very old, it's from the year 2012, shows that 77% of people infected with HIV experience discrimination. And what we need to strengthen here very clearly, and it was mentioned before as well, we need to fight the stigma and strengthen as well the health literacy in our populations. Otherwise, we'll never reach the goal of to eliminate the threat of HIV by 2030. Thank you.
Thank you, Andrew. Elena Brinjeva, you are the head of Health Without Borders. That's a Bulgarian NGO. Health Without Borders also runs Checkpoint Sofia, which is sort of an easy place to access for people to get HIV testing. Bulgaria has pretty low incidence of HIV. So, you know, meeting these 95, 95, 95 goals, that should be no problem for you, right?
It looks like. Hi, Sarah. Thank you for your invitation. And on the first place, yes, when we speak about Bulgaria, everybody says that it's low prevalence country, and that's one of the reasons that the country is not an object of interest of international organization and politicians, because usually when the numbers are high, the interest is also high to the particular country. But I want to announce a problem of this small country, which nowadays is facing and struggling with severe political crisis, because we have elections, we have now extra elections, we are with temporary government, and from mid of 2017, we have no support, governmental, national support for HIV prevention services. This will come to a very, I think, hidden epidemic, and we will have no idea after a year probably, because 4 years we are living with the single projects from different organizations who are working in the with all the groups and risk, and with many tests provided for general population. As in the governmental places, if we don't want to do business as usual, because governmental places are usually closed now because of COVID, the access for testing for Bulgarian people is limited. And I need to announce this. Our small center in the capital of Bulgaria, Sofia, is discovering 25% every year from newly cases, and is doing integrated services. I would like somebody to listen that the most important thing to reach these goals, 95, 95, 95, will be to provide really focused, tailored services for different groups. If you don't work intensively and with interest from the politician side, the access will be very low. We will have a hidden epidemic, and we will stay again in the statistics like low prevalence country of HIV.
Thank you, Elena. Yeah, and you and I first spoke when I was writing one of our case studies for our Telescope project, looking at what happened when the Global Fund pulled back from Bulgaria. It's technically a rich enough country that it does not qualify for funding, but we're now in this situation where a European Union country is struggling with providing basic prevention and harm reduction services. Manuel, you're an MEP. You're from a country that really pioneered harm reduction and prevention. You know, does Brussels, does the European Union as a whole have an obligation to help countries like Bulgaria, other countries maybe in Eastern Europe that are struggling a bit with providing these services?
Yes,
Well,
we need.
for me, it's obvious.
Yeah, let's hear Manuel, and then Elena will go back.
Yeah. Okay.
Excuse me. For me, it's obvious. When I was very happy when I heard the President of the Commission, Mrs. von der Leyen, in last September, addressing to the European Parliament in the speech about State of the Union, and saying that she's committed to a priority, to a new priority, the European Health Union. For me, it's obvious that in the health issues, we should have a more deep cooperation between different countries of the European Union and a more commitment, a more large commitment from the European Commission. I think we can be happy because now we have a very much strong health program from the EU for Health, with a 5.1 billion euros of budget. It's not a so big budget, but it's 13 times more than in previous years. So it's an important source of financing, but mainly we must do some pressure in the European Council and in the European Commission, because in a lot of issues like HIV infection, we can go further, we can do better if we cooperate more, we give support to those initiatives, and mainly we should do in everywhere, in each of the 27 countries, we should use the best experience that each country has, and I think that it's not in our hands to do that in HIV infections and in other health issues. I must point out that in a recent Eurobarometer published, 89% of European citizens want more intervention of EU in social and health issues, and I think that we must hear what European citizens want from EU.
Indeed, but you know, it was the COVID crisis that really prompted all this discussion about a European health union, that prompted this extra funding. It's not clear that money would necessarily go to HIV, and so I want to actually go to an audience question on this point. How do we convince world leaders to invest in fighting AIDS in the context of COVID? And this person points to the sense that it's a low priority in the UK with years of cuts to sexual health services and global aid. This did indeed just happen in the UK, cutting funding to some major global services. Vinay, do you want to weigh in first on that one?
If I can, thanks for the really important question. I mean, what would be really frustrating is if we put all of our focus, all of the global focus, national focus, and even European focus on ending COVID and forget about HIV. And forget about the fact that, you know, last year we still had 1.5 million new HIV infections globally, that we still had 690,000 people that died of a completely avoidable disease and a completely preventable virus, which is HIV. And that so much time and effort will be focused only on COVID, and then we will end COVID in a year or two, we hope, and then we will still have a global AIDS pandemic that is not on track to be ended by 2030, even though all countries in the world have agreed, actually just at the beginning of June, that we need to end AIDS by 2030, and these are the ambitious things that need to be done by 2025. And so there's a few practical things that can be done. First of all, let me highlight both special thanks to Germany, to Portugal, and to amazing leadership we're getting from the European Commission and from the European Union on HIV and on COVID. I mean, in Portugal, there was a prime minister not that long ago that is now the Secretary General of the United Nations, Mr. Antonio Guterres, that actually pioneered, as Manuel had pointed out, very innovative approaches, which were innovative at the time, but they've really borne fruit, and Portugal's actually on track to minimize new HIV infections and be one of the first European countries to actually end AIDS by 2030. And fantastic leadership we're also getting from Germany consistently on global health, including on HIV. But there is this, from a UNAIDS point of view, there is this very troubling divide we have even within Europe, where we have over 30 years of investment to end AIDS in the European context and within European member states. And then in the last mile, we don't see that leadership being maintained or moved forward by all EU member states. And we can see it really in many of the countries in Southern Europe and Eastern Europe that don't have the data. Elena's provided some really practical examples of how the COVID pandemic has actually made HIV take a backseat because resources and attention for HIV, even in the last year and a half, are not what they used to be. And so we need to be able to end pandemics simultaneously. We need to make progress against COVID-19 and against HIV at the same time. Otherwise, we're going to lose very precious time focusing much needed attention on COVID, but not at the expense of HIV.
Thanks, Elena. Back to you, and then I'll go to Andrew. You and I spoke about how HIV hasn't really been a priority for the various governments that you've been working with in Bulgaria, even before COVID. So can you just give us a sense of what that issue is, why it hasn't been a priority, and what your strategies are to kind of get more attention?
On the first place, before, when the Global Fund was there, everything was okay. There was political will, and it's very important this to be here for the countries which will face these difficulties when the Global Fund goes out. When the Global Fund withdraws, everything freezed, and our politicians try to make some changes and to adapt to cope with the epidemic with national resources. This ended up with a lot of roundtables, a lot of meetings, a lot of initiatives, and at the end, we are still without proper financial mechanism for national financing of the projects for NGOs. On this stage, we have no harm reduction programs, which we didn't have from 2 years. And believe me, in the group of drug users, it's a huge problem. Nobody knows. As the previous colleague said, there is no estimations. Bulgaria is one of the countries that is not likely to provide estimations, so we don't know what is the average of our groups, even by cities or national statistic, is poor. So on this stage, we are trying to raise the attention for national policies, because if you have no national policies, you could not go ahead and follow your goals. For example, the national program to fight AIDS 2021-2025 is somewhere in the administration desks. 8 months. We are without national program. So we are trying to make and focus the attentions of our politicians, but now we are in political crisis. We have no parliament, we have no government, and we are waiting to build our strategies after the elections in July.
Mm-hmm. Yes, very stark reminder of how dependent the HIV response can be on just sort of the status of the national government. Of course, global health leadership is also very important. And Andrew, Germany has really, over the past few years, but especially sort of during the Trump COVID era, Germany has really asserted itself more on the global health stage. And so with that in mind, I'm also going to ask another one of our audience questions. With so few lessons in the COVID-19 response, I think this trying to say we didn't take much of the lessons from HIV and use them in COVID-19, but are there lessons from COVID that can be taken to improve the HIV response?
Well, I would say there are plenty of lessons learned with the pandemic of COVID-19 because there were a lot of mistakes done on a national level. And what we also didn't realize is the simple fact that multilateralism in global health was not existent when the COVID-19 crisis occurred. International health regulations were not in place in every country. Information flow was devastating, unsatisfactory that we were facing, and we had issues how to tackle the pandemic, and it was simple notion with lockdown or let's close the borders and everything will be fine. But people do not understand the dynamics of a pandemic, and what was made very clear is only through multilateral cooperations a pandemic can be fought with, and HIV is also a pandemic where we learned a lot from, but the transmission going down to science was of course a totally different story, and I would say that's one of the major reasons why lessons from the HIV area were not actually put into place for the COVID-19 lessons. But I think we have a chance learning from the COVID-19 pandemic, seeing how international cooperations could look like for surveillance, see how healthcare systems can be strengthened, because that is also a big issue, which is very important. The healthcare systems have to be more resilient for a pandemic that all of a sudden pops up. And we have to realize that we cannot drop our guards once we have a new pandemic on the horizon. It doesn't really matter if it's a coronavirus or a flu virus. It really doesn't make a big difference. We have to be aware that diseases are occurring again and again. And we were talking about HIV and COVID-19. I'd like to also mention the neglected tropical diseases in African states, for example, that aren't necessary. Excuse me? Oh, sorry.
Sorry, please continue.
It was, yeah, of course. And so we have to start to work together as a community. And for example, the role that Germany will take next year for the G7 presidency might actually revise the multilateralism cooperations that we need in the fight against diseases, and not only communicable disease, non-communicable diseases as well. So there's a lot of homework still to be done by the politics, and that's why we're sitting here.
Thank you, Andrew. And that's actually a great segue to another thing that I wanted to ask about. We did just see the UN high-level declaration on HIV, which was an affirmation on this new UN/AIDS strategy. But of course, we saw some of those challenges in the multilateral system that have become all too familiar during the COVID era. There were some countries, most notably Russia, that were very concerned about references to sexuality and sexual education. Vinay, looking at the discussion that happened at the UN on this declaration, did that affect your confidence about the political will to move forward with this strategy?
Was it a sign of concern, and was it a little bit frustrating? Definitely. But even if Russia didn't vote in support of the high-level meeting political declaration of the General Assembly in New York, they did support the consensus adoption of the global AIDS strategy of the UN/AIDS PCP here in Geneva at the end of March. So we have a global AIDS strategy that very specifically commits all countries and all communities to end AIDS by 2030. But just assuming that we can be the UN and we can wave around a declaration or a strategy that was endorsed by consensus in any multilateral forum is not going to move us forward in terms of getting it implemented. And so now there's a lot of urgent heavy lifting to have these things kind of internalized, nationalized, get exactly what the other colleagues on the call are talking about, get the political engagement to move these things forward urgently, because every day we waste is costing lives. Every day we put it off and say, oh, well, we've got COVID, or we need to wait for the next budget cycle, or we need to wait for the next planning cycle. Well, this is an epidemic that cannot wait to be ended. It has to be ended in less than 10 years, by the end of 2030. And so we've got a lot of urgent work to do. We as UN/AIDS, as a joint program, can't do this alone. We really look to our partnership and collaboration and support from and for member states to take this forward.
Thank you. And another thing in that strategy are 10-10-10 goals, and that's reducing the proportion of countries that have sort of certain obstacles to the HIV fight. And one of those is and Vinay, correct me if I'm mischaracterizing, but basically fewer than 10% of countries would have laws that criminalize or further stigmatize people who are vulnerable to HIV. And Manuel, so I want to go back to the Portuguese experience experience. As you noted earlier in the discussion, Portugal was a trailblazer in decriminalizing drug use, and that really helped with harm reduction and prevention programs. I think there are also discussions about whether sex work should be decriminalized. Other countries are, weighing whether they want to take these further steps. What would you say to a national leader who says, I hear your public health argument about harm reduction and decriminalizing drug use, but I don't know. I don't know if it's gonna play well with my domestic audience, and I'm just a little bit nervous about it. What would you say to reassure them?
Well, perhaps the best idea was to invite them to visit Portugal. Because when we debate that at the end of the 90s, when the actual Secretary General of the United Nations was Prime Minister in Portugal, Antonio Guterres, the discussion was that it will be horrible. A lot of people will come from around the world to go to Portugal to inject drugs and things like those. And what happens is that drugs became less and less an important problem for people in Portugal. Why? Because it was not logical to say that the drug addiction is a disease, and our societal response to a disease was to criminalize the disease, was to get police and judicial system against people. The people need health system and social support. And with that kind of answer, really the problem was well, not solved. Of course, it's impossible to solve the issue of drug abuse, but it's far less important than it was before. And I must come back to something that Andrew told that I think is very important, is the issue of prevention. And the first thing that we must do on prevention is to engage in health literacy. And we must debate those things openly, because a lot of them, we should see them in a comprehensive manner. To tackle HIV infection is also to tackle viral hepatitis and to tackle tuberculosis, because in a lot of countries, the main driver of tuberculosis epidemic is HIV infection. So if we must give people, mostly young people, but all the population, with health literacy. And I think that we really must invest on that, because we cannot have a paternalistic approach for the health issues, that the health professionals say things and people will behave like that. It doesn't work like that. We need to have really citizenship from people, and we must give people information and a capability of doing informed choices about the health issues. I think that is the most important investment that we should do.
Thank you. Elena, on that point, what is the status of kind of the general public's health literacy in Bulgaria? And of course, we've been talking about the government, but people choose their government. So is there something to be done to garner more kind of support and understanding among the general public?
We did a lot of campaigns among general public, and a national study from 2018 shows that the level of stigma is very high. Generally speaking, the nationalists are very these traditional family supporters in Bulgaria, and are very strong for part of the society. And usually when we speak about HIV, the stigma was put directly on the person, like a stamp. I could say that last few years there is a small improvement because of visibility of people who don't want to keep silent anymore, but usually there is a lot to do in terms of stigma among groups. And when we speak about the society and risk, for example, nobody wants to have in the small municipality, for example, methadone programs. They made protests, all the mayors go there supporting them. It's really difficult to proceed, but with slow steps, I think we need to go ahead.
Mm-hmm. Thank you. And I'm going to close on a sciencey question that we got from Julien in the audience. It's one that I think is understandably on a lot of people's minds. I heard the HIV vaccine can hardly be developed because there are now too many variants of the virus. Is this true? So, who's up for tackling that one? Andrew, I think you said earlier that you would be able to do it. So.
Yeah, I'll try the first hit, and maybe some of my colleagues could jump in.
Right.
It is true that HIV is a quasi-species, and then there's a lot of variants of HIV. However, there are some conserved areas of the virus which are immunogenic. The big challenge I would see is not the immunogenicity of the virus itself, it's the hiding of the virus. The hiding of the virus in compartments, in tissue compartments in the human body, such as brain tissue or nerve tissue or testicular tissues, that could be very challenging for the immune system to tackle if it doesn't go through there. So it's not only the variants of the virus that seems to be a challenge, it's also a question of the compartment where the immune response has to take place.
Thank you. Anybody want to add to that, or? Only
a small detail, because you should see that I'm sure about that. When you discover a treatment for a disease, it's rare to have the same investment in the vaccination process. Normally, to general diseases, or we have treatment or we have vaccines. And of course, there are technical issues about vaccine on the HIV, but it will be possible if there is enough scientific and technical investment on that. The variability is a problem, but this is not the main concern in the investigation of a vaccine.
Thank you, Vinay. And this will be the last note on helping all of our health literacy here.
Well, just quickly to add, and completely agree with the points made by colleagues, just to emphasize that there has been so much amazing progress just in the last year on developing and rolling out COVID vaccines. Clearly not in an equitable way, when billions of people around the world are still waiting for COVID vaccines, but it's actually 30 years of investment in the development of an HIV vaccine that actually led to many of the breakthroughs that finally gave us a range of COVID vaccines. Unfortunately, we still don't have an effective HIV vaccine, but there is a huge, unprecedented amount of work being done on the development and clinical trials or vaccine trials rather of an HIV vaccine as we speak. So we're getting closer. We're still not there. And this is one of the things that the political declaration highlighted at the beginning of June in New York, that we need to learn the lessons of how to fast track the development of scientific progress to make sure that both a vaccine and a functional cure actually helps speed the way towards ending AIDS by 2030.
All right, thank you. A perfect note to end on, Vinay. I really appreciate it. Thank you so much to our first panel. Don't leave if you're watching online, because we're bringing up another discussion. But before I bring on our next speakers, let's maybe take a peek at that word cloud one more time, see if this last talk had any. Education has now grown on the list. I see affordable prevention, access in a couple different ways. But thanks to everybody who filled that out. Let's go ahead and move on to our second panel. This telescope project has had 2 chapters, and this second chapter has focused on case studies, drilling into sort of innovative and original efforts to solve problems in HIV. And the next 2 panelists really were key players in those 2 case studies. And Jeff Lazarus, you are the head of the Health Systems Research Group at IS Global and associate professor at the University of Barcelona. You were pushing to add a fourth 90 in the UNAIDS declaration, or let's say a fourth 95 now, that would have focused on health-related quality of life. So now people, if they are diagnosed and on treatment and virally suppressed, they can live sort of a normal lifespan, but they may face other health challenges. And Jen Werner, you are the social impact investing consultant for the Elton John AIDS Foundation. We looked at your this really innovative effort to fund and garner government support for funding an HIV diagnosis and treatment program to kind of find those last few people in London who still are not being connected to care. And the thing that stood out to me about both of the efforts that you were involved in is they really represent to me kind of the modern face of the fight against HIV, whether it's finding those hard to find people in a city that is otherwise doing really well, or it's looking at kind of the next generation of challenge for people who are surviving and getting effective treatment. So Jeff, let's start with you. What kind of, over the past 40 years, how have you seen the fight against HIV evolve, and how has your effort to focus on health-related quality of life, where do you kind of see that going over the next 10 years? And I know it's a big question.
Thanks for...
We'll keep the answers relatively short.
I'll do my best. So thanks, Sarah, for having me, and thanks for bringing this issue up. And I'm really pleased to speak on it. There's so many people who have been involved. And we need to always recognize, as I'm sure Vinny and everyone will agree, that we haven't reached the 390s everywhere, not even in all European countries, and certainly not in many of the marginalized populations. Still, I think it's within HIV and AIDS that it behooves us to focus on where do we want to go next. And that's about having good health-related quality of life for everyone living with HIV. And that's why we proposed what we called the fourth 90, because there were 390s. Now there's 395s. And I think the debate has really moved a bit. So it's not so much more about having a fourth 95. It's now we see that health-related quality of life is incorporated into the new UNAIDS strategy. So there's, as you mentioned, there's a specific targets set around reducing stigma and discrimination. The issues of comorbidities is more visible, and related issues about engaging with the population and listening to them to report on on how they feel they're doing. That what we call PROMs or patient-reported outcomes. So we see that there's been a success, that it's been incorporated into the current strategy, just in different wording.
Mm-hmm. Thanks. And Jen, the social impact bond really focused on patient engagement also, but maybe in a different direction. Can you tell us a bit more about kind of this extra level of engagement with a vulnerable community? I think your volume is, I don't know if you're muted on your end. All right, Jeff, I'm gonna move back to you while we work on Jen's audio. But can you kind of tell us what kind of the key challenges for health-related quality of life are? Are people more vulnerable to other types of diseases?
Well, it was interesting when you showed the word cloud. I would say that the key challenge is just understanding what HRQOL is, defining it and understanding how important it is for everyone living with HIV. So people living with HIV, as you mentioned at the start, or Neil did, are living long and can live, have a normal life expectancy, can be healthy throughout their life and develop comorbidities of aging, or comorbidities because they started on their treatment late because the guidelines were different then. So we need to recognize a whole situation around non-communicable diseases and comorbidities that we didn't a long time ago when we were really just in emergency mode trying to identify everyone living with HIV and link them to care and make sure that the treatment they were receiving was actually suppressing the virus. The other issue is really listening to the people. This has been a hallmark of HIV. Nothing for us without us, the greater involvement of people with AIDS, the meaningful involvement of people living with AIDS. And now we have tools, we have these prompts, these patient-related outcome measures that are well tried and tested, but we're not using them in most countries. We're not listening to the population, so we don't know what their concerns are, what's stopping them from accessing the health system, why they may not be adhering to their treatment, or why they might not even be coming forward in the first place to get diagnosed. So we're seeing all of this sort of encompassed within HRQOL, and as UNAIDS did so well, particularly identifying, reducing stigma, reducing discrimination. There are still discriminatory laws and rules and regulations in so many countries that need to be addressed.
And one of the challenges, though, is measuring something as broad as health-related quality of life. And you mentioned kind of talking to patients. Are we developing ways of actually, if we were to have created a fourth 90, how would a country have claimed that they could check that box?
I think that was the most complicated about it. It doesn't sort of exist unless you're measuring it properly. And there were a lot of debates. So when we started and we spoke with many clinicians, they said HRQOL is really about, how you're doing with your treatment, that we're not seeing any adverse events or drug-drug interactions. The community said, this is really about how we report how we're doing. So we saw that it had to be two-pronged. And then through discussions over the years, we realized we really had to address stigma and discrimination. And I would say in particular, although there's tools for both, in particular discrimination, making sure there's no discriminatory laws like the criminalization that was mentioned. When I was at WHO 15 years ago, almost half of the countries in the world had travel restrictions for people living with HIV. So UNAIDS and WHO have strong monitoring and evaluation frameworks that are now being updated with the new strategy. And they'll be able to look at, what are the 395s, what are the 310s, and how are countries doing. I think the one part that's still missing is how do we engage the population? So the ECDC, the European Center for Disease Control, had a question on the Dublin Declaration monitoring a couple of years ago, where they asked countries, are you measuring health-related quality of life? When was the last time you did this?
Can you just remind us what the Dublin Declaration is?
So the Dublin Declaration was the follow-up of a ministerial conference held in Ireland when ministers from all 53 member states of WHO, not just the members or the ministers of the European Union, got together and made a declaration. And to their credit, and this doesn't happen in all declarations, in the last paragraph, they said, we commit to monitoring this every 2 years. And so when I was at WHO, the director of the HIV program, Sergio Matic, said, well, let's hold them to it and let's start measuring this. So we prepared the first Dublin report, which eventually became the official monitoring framework of ECDC and WHO, and is handled so well, engaging with the populations and having meetings, including with the community, to make sure it's updated every 2 years. And so they asked a question a couple of years ago, like I said, are countries monitoring HRQOL? What tools are they using? And only 5 of 53 countries were doing that. So we can see that there's still a long way to go deciding what to ask and how often to ask it of people living with HIV.
And is this something that should be worked on, do you think, at the European level, collecting this type of data, or are the needs of patients going to be unique to each country?
Well, the needs are going to be unique to every country, but I think we can have a tool that's broad enough to be used, a tool that will have different domains. I mean, there are short tools, like the EQ5D, which is just 5 questions. There are longer tools, 36 questions, even more. So we need to really pilot and see how likely are we to have a representative sample, responding to the particular tool, and then we can, if it's comparable, we can look at the differences between countries and start to have European action on this. So I think it's incredibly important for the Commission, for the Parliament, as they legislate, as they support activities at the European level, to have that voice, the voice of the people living with HIV.
And I think anybody watching TV news in Spain or in Denmark, I think, has seen you talking about COVID on TV a lot. Am I right about that? You are definitely well suited to speak about both. So I'm gonna toss you one of the questions that we had earlier about the lessons of COVID versus the lessons of HIV. Are there lessons that we're learning from COVID that we can apply to HIV going forward?
There certainly are, and they actually reinforce many of the messages from HIV. You know, the response to COVID has not done well in engaging the population. I understand at the beginning it was, the pandemic was an emergency and pandemic control measures were put in place. But when we asked, around 19 countries, a representative sample of the population, what do you think? What's your perception of the response of the government in 10 different areas? All of the governments failed. They weren't communicating well. They weren't engaging with the population. So again, with HIV, as we move forward into this new era, this almost a beyond viral suppression era for many people, fortunately, we need to continue to engage with them. So I think that's a key lesson from COVID. The other issue is that, pandemics don't end from one day to the other. I hope COVID-19 will end soon, but it looks like it's going to be with us for a while. And if we don't address, as Vinay said, the marginalized populations, the vulnerable populations, we're not going to make the progress we need to end the pandemic. And that's been plaguing us in addressing HIV and AIDS, is really making sure that when you have 90-90-90, it's not just the whole population, but it's also for the prisoners and for the sex workers and the migrants and the people who use drugs, the homeless, and any other population that may not be achieving the same kinds of outcomes as others.
Thanks, Jeff. And I think we have Jen with us. Can we do a quick sound check? You here with us, Jen?
Of course. Hi, guys.
Excellent, excellent. Thanks for bearing with us. So yeah, we were just talking about lessons from COVID-19 for HIV. Jeff made this point about vulnerable populations. What has the social impact bond kind of taught us about getting to these hard to reach groups?
Completely. Yeah, I heard the end of that conversation, and I think it's such a good transition to this work. England provides free, high quality, accessible healthcare, and it's reached 90-90-90 already. But as Vinay pointed out earlier, 95-95-95 is more about subpopulations. And individuals perceive and experience the health system in very different ways, informed by cultural opinions, fear, stigma, practical concerns. So a system that's technically available to everyone, but it's practically not accessed by certain populations is insufficient. So our work has really started with a robust ethnographic piece of research in one South London borough. We found a number of barriers that were specific to people with Black African ethnicity and those who are recent immigrants. And then we created a program with interventions tailored to those needs and experiences, finally extending this into practice with an innovative funding mechanism. So all of this work really has been grounded on trying to find those subpopulations and learn not just what is available to them, but what would actually practically be accessible and acceptable to them.
Mm-hmm. And another issue that we've seen throughout the Telescope series is stigma among healthcare professionals, and your project really, Jen, relies heavily on engagement from healthcare professionals, encouraging people to get HIV tests. What can we learn about that, about the messages that work best with health professionals?
Completely. Well, education is a huge piece of it, and cultural change over time is a huge piece of it. We've developed something that's really got a lot of connective tissue between hospitals, clinics, GP federations, and all of this learning has to really be guided both by people living with HIV and by the clinicians themselves. So it's been a really collaborative process of people sharing the experiences that they've had through this program and sharing the experiences of their clinician partners and just trying to change the way that they all deliver services in a way that is more patient focused. A lot of it's just elevating those voices in a way that they hadn't thought about previously.
Mm-hmm. And Jeff, also, improving health-related quality of life for people living with HIV involves more engagement from non-HIV specialists. Briefly, what are kind of the key things the best practices that you found there?
Well, it's really a whole of system approach. Again, something we learned and are trying to learn from the COVID-19 pandemic. So this is about engaging primary care. Maybe people living with HIV don't need to go to the hospital and see a specialist as much as they did earlier, particularly those who are virally suppressed. It's about having community pharmacies more active. So there's a number of different ways to engage throughout the health system instead of how we were doing it before in just seeing an HIV specialist. There'll be a time when ID specialists, infectious disease specialists need to be engaged, but with the increasing prevalence of comorbidities, we're going to need multidisciplinary teams. We're going to need to think about how we move forward with telemedicine and the challenges that some populations will have with that. But we have a whole world of opportunities with digital health, with wearables, and we can start treating people rather than just treating the virus.
Mm-hmm. Jen, I'll give you the last word here, kind of your final reflections.
I'd say that what Jeff just pointed out in kind of where we need to extend and deepen the treatment itself is also much of the solution to finding individuals and bringing them into HIV care. Really listening to needs and digging in on individual experiences and subpopulation experiences, and making and bringing interventions to settings that are non-specialist sexual health services, like doing universal testing or doing community-based testing. It is really a lot of how we can bring people in the first place. So sexual health services, really might sit more rightly as one piece of the stream of experience, but wouldn't be the only piece.
Mm-hmm. Thanks so much, Jen. That's a great point to end on. I mean, what really stood out for me from the discussion between you two is HIV used to be subject to some exceptionalism, and that may have benefited it. That's why we have a UN agency devoted to it, and we have these high level declarations. But at the same time, now it's important for it to be more kind of integrated into just the regular provision of healthcare services, and that also means listening more to the community, better integrating healthcare professionals and making sure they're aware of issues. And broadly, our discussion, I think, really, as our word cloud reflects, we saw the importance of political will, especially at the national level, and how that plays out at the international level is key to meeting these 2030 goals of eliminating AIDS as a public health threat. And likewise, COVID brings lessons. HIV helped the COVID response as far as lessons about public health, lessons about stigmatization that we maybe didn't use, but lessons about a vaccine that we did use. And now we're learning things from COVID that may help us kind of finally close the gap on HIV. So I'd like to thank all of our panelists, both from the first panel, and Jeff and Jen, to you as well. Thanks so much to our audience online. Thanks to Gilead for making this event possible. We love your feedback, so please do send it to live@politico.eu. And stay tuned for all of our upcoming events, politico.eu/events/future-events. And there will be one more Telescope newsletter, one more case study coming to you, as well as a wrap-up of this event. So you can also go to our Telescope hub to subscribe to the final newsletter. Thanks so much to everybody. Have a good afternoon.